So physicians should know the root causes of these health inequities, right? Unfortunately, this is not something that everyone has learned, not in undergrad, not in medical school, not in training. And in fact, bias amongst healthcare providers usually just gets reinforced by training because generally speaking, the people who go into medicine are from relatively privileged backgrounds, not exactly diverse, definitely not representative of the general population. And then the people who they interact with, the patients that they care for, especially during training, are from completely different backgrounds. And as a physician, you only see what you see, right? And you carry with you all of the stereotypes and things that you've learned throughout your lifetime. And when you see these health inequities and in front of your face, but you're not able to see the whole picture because you're not from that culture, you don't live in the neighborhood, you don't have those experiences, it really limits one's ability to be able to recognize the bigger structural forces. It also, unfortunately, limits one's ability to recognize bias in themselves because there's, of course, the confirmation bias. They're just unhealthy because of something they did, or, I see this issue in all of those people. It must be something biological. And I've seen that come up over and over again during the COVID pandemic. So we're going to take a few minutes just to go over how bad it really is in medicine. So this tweet came out to promote a podcast, and look at the language. No physician is racist. So how can there be structural racism in healthcare? And I think that, probably the original plan was to try to sell this idea to people who were skeptical, which is like a lot of people, probably most people in medicine. But they ended up talking about how, racism, that word is just too icky and it turns away white people. They need to change the word. And so there is really a limited ability to see bias, one's own bias. And then this gym happened about a year ago, because if we have a limited ability to really see our own complicity in the situation, then we probably aren't going to come up with the best ideas, right? So this was a tackling or talking diversity, majority minority, men's perspective of inclusion. So because most of the healthcare providers or people working in the hospital were women, they wanted to have a panel of men talk about what it was like to be a minority. But the thing is, what we're talking about here doesn't really have to do with minority. In fact, globally, people of color are the majority. So that term is outdated a little bit. We're talking about power dynamics, right? And so their diversity panel, even though 79% of the workers were women, their marginalized diversity panel consisted of a senior vice president, a nurse manager, a director, senior HR business partner, and nurse manager, all very powerful roles. So I think that they're missing the point here. And then when we talk to patients, we know that 33% of Black women have said that they have personally been discriminated against because of their race when going to the doctor or health clinic. 21% said that they've avoided going to a doctor or seeking healthcare out of concern that they would be racially discriminated against. And this is something that I see in my practice, especially when a mom, is struggling during that newborn period, maybe dealing with postpartum depression or anxiety, or like bleeding, or any of the other things that can go wrong during the postpartum period, if she had a bad experience during her OB care and felt discriminated against, she's not following up with that OB. And a lot of women, especially who are facing, socioeconomic disadvantage, particularly women of color, really only have a short period of time to get healthcare. And if they are not wanting to seek it out because of, traumatic experiences, then that means what we're doing is causing harm and death, actually. So what do they mean by discrimination, right? There was another study that in this questionnaire, it was 17% reported mistreatment by providers. So about 9% were scolded or shouted at by a provider. About 8% had providers delay care, which this is from the patient's perspective, but other studies from a healthcare perspective have shown that this happens a lot. This is the norm to delay care with especially Black patients. About 6% reported violations of physical privacy. So maybe not being covered when you should have been covered, right? Feeling exploited. And almost 5% were threatened by the withholding of treatment or given treatment the patient did not consent to. And that sounds extreme. And I'm sure that there will be doubts for people who are watching this video. But, if you still have doubts, like I can tell you probably a million stories where I've personally experienced this or have seen this. This is probably a gross underestimation, right? Because most people don't want to believe that their physician is discriminating against them or treating them in a manner, that isn't equal to other people. And oftentimes from the patient's perspective, you don't know how they're going to treat other people. And so I will tell you, this is probably an, underestimate. And that's not the only thing that Black patients have to deal with, right? Because they're also being discriminated against at work, in their neighborhoods, at school, everywhere. And so, it's less in healthcare, but it actually causes death. So, the stakes are high. In Los Angeles, we have data for women who have experienced discrimination. And notice all races report this, but it might not be a racial discrimination, right? They might have felt discriminated against because they were women. So one, egregious example, this was relatively recent, September 2020, an Indigenous woman records slurs by hospital staff before her death. 2 women at the hospital are heard calling her stupid and saying she's only good for sex and would be better off dead. And I think that was before they were putting her under for surgery, which she died. There was another wife of a physical disabled patient in Texas who recorded the physician saying that they're just not going to try. They're not going to give life-sustaining support because they don't think that their life is worth living. Although he had a family and a wife and an enjoyable life because he was physically disabled and Black. Why try? Because in the perspective of the white physician, it seems futile. So US racial and ethnic minorities are less likely to receive preventative medical treatments, often receive lower quality of care, more likely to deliver in different and lower quality hospitals, and that we're specifically referencing, pregnancy-related illnesses, less likely to have access to vital reproductive health services, less likely to receive pain medicine, and more likely to be drug tested. The drug testing part, has created mass inequities. This is part of the way that physicians help shunt people into prison, or, inadvertently, or, on purpose, deal with or like help facilitate child separation, family separation. So we are complicit in this too. And so we are doing ourselves and our patients a disservice if we don't recognize the bias in medicine. And for sure, ignored or dismissed. I've had pediatric patients who are, who have crush injuries on their arms, and who, have so much swelling and inflammation and damage that they weren't even able to like fix it in the first surgery. They have to like just cover it with plastic and let it, the swelling go down a little bit before they go back in there, which that's like horribly traumatizing, right? Your arm is filleted open, you're in horrible pain. And I've had the nurse refuse to give that patient pain medicine because from her perspective, she definitely wasn't a racist, but the size of the teenager, he was a football player and he was Black. Her statement was, that big old Black boy, he doesn't need pain medicine, he's not hurt. When he's tearful and has a horrifically traumatic injury. And, unfortunately, that patient had to be the one to call it out. And he was right. That was racist treatment. And it wasn't even implicit, right? Like that was an explicit statement that the nurse said. And she got mad that like it was called out. And so what do we do in that situation? Ideally, we would have staff training, but, or switch, to someone else. Unfortunately, Black patients will have to deal with this more often than not. And so we have to figure out a way to, change the system and change the culture. So as mentioned in the previous example, explicit beliefs about white supremacy, differences in Black bodies, and implicit bias are very common in medicine. And so explicit beliefs, the difference is that you like acknowledge it, you say it out loud, you say the silent part out loud or whatever. Implicit bias is like, no, that that's not true. There's no biologic, difference in race. It's a social construct. You are, woke AF, but you were still raised in a society that shows, stereotypical pictures that reinforces these like beliefs about differences. And so even though like, your frontal lobe knows that these things aren't true, your entire life, has been spent in this racist society. So it's something that's under the radar, that there's no way that you would be able to just like know that you have it or not. And again, when we're talking about racial health inequities, we're talking about racism, and this is part of it. Let's look at a couple other examples. So in 1999, physicians reviewed videotaped actors who displayed the same symptoms, all the same, of cardiac disease. And they were significantly less likely to recommend, life-saving treatment, the standard of care treatment for Black female patients exhibiting the same symptoms. So not even in an experimental setting where, maybe something might have tipped you off, that they were like studying this, still there was a resistance to refer Black female patients to the correct care, even when they were displaying the same symptoms. Also, there was another study where mental health professionals subliminally were primed with African American stereotype-laden words. And so they didn't even bring up race. They just primed them with like stereotypical words. And we'll learn more about priming in the actual biology of bias, right? And after this, they were more likely to evaluate the same hypothetical patient, race not identified at all, more negatively than when primed with neutral words. So that's where this implicit bias comes in. Like, even if we're not even talking about race, like you have been conditioned to associate race with a negative emotion and a stereotype. And so even priming with something down the line, a stereotypical word, will still bring up that negative emotion, and you'll treat patients differently because of that. But that's a really hard pill to swallow. Physicians don't like being taught or told that they're biased or they treat people differently, but we have to acknowledge this and recognize that we're all susceptible to this. In 2000, doctors rated Black patients as less intelligent, less educated, more likely to abuse drugs and alcohol, more likely to fail to comply with medical advice, more likely to lack social support, and less likely to participate in cardiac rehab than white patients. Even after they controlled for income, education, and personality characteristics. So even after controlling that, they still had these negative perceptions about Black patients. And this is really kind of just reflective of the culture and the negative perceptions that are rampant about Black people amongst non-physicians too. Physicians are human. In 2016, and the John Oliver video, mentioned this, that many white med students and residents still hold false beliefs about biological differences between Black people and white people. And, if it just stopped there, it'd be fine, maybe, I guess. But those with the false beliefs also treated patients differently based on their race. Like, they didn't give as much pain medicine to the Black patients. In this particular experiment, they actually just like over-treated the white patients. And that is very relevant, actually, because this shows an example of how even when it's a positive bias towards like your own tribe, you can still cause harm if you're not going to acknowledge it, because they overdid it with the pain treatment. And that's kind of what we see with this opioid epidemic. Because physicians in general think that Black people are going to abuse, medically necessary pain treatment, they don't prescribe it to them, but they do overprescribe it to their own tribe. We also have other biases. So physicians have been shown to attribute obesity with poor hygiene, non-adherence, and dishonesty. And 53% of overweight and obese women reported receiving inappropriate comments about weight from their doctor. And so your brain probably goes to like, well, were they just bringing it up because they needed to address it in the exam? No. So I don't know what they specifically were referring to in this study. But another example I will give you, an egregious example, where we were at a free clinic, a free health clinic. So really serving like indigent population, homeless population, people who have experienced a lifetime of trauma. And a woman is there for depression, and she's tearful and crying and really just struggling and needs help. And the physician who is supervising me and teaching me walks in and directly starts talking about her weight, something she did not even come in for. There was another physician who grabbed the abdomen of a patient and wiggled it and said, "That's too many biscuits right there." They were not there for weight issues at all. So like these things can be just ridiculous, really hard to believe. But, it's important that we shine a light on it because it's not going to change if we don't. And obese patients who report perceptions of weight discrimination avoid seeking routine preventative care. And so, it's not just being like a jerk, it's actually impacting lives and impacting health. And, we're stepping on our own toes by preventing, people from accessing us. These were studies among med students. So it's not just like old people who are about to retire, right? And that might have been your own implicit bias, right? It's also young people. And so explicit versus implicit, remember explicit, I'm going to say it out loud because that's what I believe in. Implicit, I don't believe in that, but I've been conditioned to actually deep down believe it. And it's high for anti-fat bias. And when they compared it to other types of bias, so this is explicit belief, look how it compared. So much higher related to anti-gay bias or anti-gay explicit, bias and beliefs. Much higher than bias against poor people, much higher against racial and ethnic groups. So this is a place we need to work on. And this is really hard to get to convince people that it's an issue. So what do we do when we have this bias and we're not going to acknowledge it? And, we don't know what we don't know because we just confirm our initial beliefs, right? So during the COVID pandemic, as you all are aware, there are racial health inequities related to COVID deaths. One lawmaker in Ohio asked if it was because the Black population doesn't wash their hands as much. So this was in a public, arena, but also this was an emergency room physician. So completely missing the point on this. And even if we are going to blame the behavior, but we shouldn't, and we shouldn't, there are other factors that are contributing to this, right? So soap dispensers, sanitizer dispensers being designed for white skin, that is a way that we program bias into our technology, into these protective, mechanisms. Also differences in the workforce. Also the culture of being scared of Black men, and then Black men are scared to, wear a mask because they, don't want to give the impression that they're dangerous. And, even Black people who grow up in this culture are not immune from participating in some of these stereotypes, and also, perpetuating this bias because the U.S. Surgeon General at the time, told people, Black and Latino Americans, to step up and stop drinking and smoking. That's not why, that doesn't explain the racial health inequities. And this was a Surgeon General. So how does this work? Well, the structures were set into motion. It's a lot easier when you understand what set them into motion. So something like redlining, right? That excluded Black families from moving to the suburbs, and then resulted in all of the economic investments being diverted to a different place than where they lived, including economic investments in school, right? And so then you get worse school, where you don't get to, have as good health or educational outcomes, and that impacts your earning potential, which also limits your resources. But then there were also, in almost every city, the highway system destroyed vibrant middle-class Black communities. And, you know, now we have like also gentrification that's also displacing people. But so we're all like conditioned within the society in which we live and work and play, right? But the more that we see it, the more that it convinces our brain that these things are just natural and, you know, probably biological or behavioral or whatever, because it's really hard to see those structures. And then it just reinforces that bias. And then we perpetuate, you know, discriminatory acts, which worsen health outcomes. Well, we don't see our part. So medicine has a huge, you know, a lot of work to do. And so we'll stop there.